This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. 2010, copyright, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I want to welcome you to today's webcast on blood gases. When do we really need them? At the completion of our program today, hang on just a second. Hang on, folks. Okay. Upon completion of the AARC webcast, participants will be able to state 4 indications for obtaining an arterial blood gas value, identify 3 situations in which arterial blood gases were commonly done in the past but may not have been indicated. 3, state 2 additional analytes available on blood gas analyzers, and cite 4 common errors which may lead to erroneous blood gas results. I am pleased to introduce William J. Malley. Bill is a registered respiratory therapist who holds a certified pulmonary function technologist credential from the MBRC. He is the director of the School of Respiratory Care at Western Pennsylvania Hospital in Pittsburgh, Pennsylvania, and is an adjunct faculty member of Indiana University of Pennsylvania, which, incidentally, awarded him its Distinguished Alumni Award. Bill is the author of 2 major textbooks in blood gas interpretation, the most recent being Clinical Blood Gases, Assessment and Intervention by Elsevier Publications in 2005. He is a frequent presenter on blood gas topics at state, national, and international meetings. Mr. Malley discloses that he has no conflict of interest with the information being presented today, and brand names of products may be mentioned simply as examples of technology. Bill, welcome to the program. Bill, you'll need to turn on your microphone, I'm afraid.
Thank you, Bill. First of all, thank you for the invitation, the privilege and the honor. And I'd like to wish all my colleagues a happy National Respiratory Care Week. So, as you said, the topic that I'm presenting is blood gases. When do we really need them? This is a very intriguing topic to me with my background in doing blood gases, and I usually or oftentimes think back at the quote that is actually in the first chapter of the textbook that says, blood gas and pH analysis has more immediacy and potential impact on patient care than any other laboratory determination. Now, this is an older quote. There's actually been a more recent one through CLSI, and this was in 2009, and they say, again, several aspects of blood pH and gas analysis are unique among clinical laboratory determinations, and at the same time, and I highlighted, no other test results have more immediate impact on patient care. So I'm always intrigued with, we are trying to reduce laboratory costs, and we certainly want to avoid unnecessary expense in this day and era. But at the same time, at what point do we need to do a blood gas? And so that's really pretty much what this presentation will have to deal with. I also will deal a little bit, as Bill said, with laboratory data error as we're trying to look at the best practice for getting a blood gas result. Again, to use a quote, in blood gas and pH analysis, an incorrect result can often be worse for the patient than no result at all. So that is one of the important considerations. So, first of all, when should we do a blood gas? What information does it provide us with? And I list the indications for blood gases as 4: acid-base assessment, ventilation assessment, and I know we've all learned in our early courses in respiratory care that PaCO2 is the only way really to know if a patient is hypo or hyperventilating. So that's an important point. We cannot visually do an inspection and make that assessment. Pulmonary oxygen exchange, which I refer to as, of course, pulmonary shunting, the degree, the effectiveness or efficiency of getting oxygen from the atmosphere and the alveoli into the pulmonary capillaries. And finally, it is a good starting point, although certainly not the end-all, for helping us determine the potential for tissue hypoxia. So I always thought to myself, any of these four things, if they are disrupted, could lead to serious morbidity and mortality. Certainly severe acidosis, alkalosis. You could probably argue maybe about ventilation. I believe I heard one physician say no patient dies from hypercapnia, but that could be argued as well. Certainly if you have a cerebral issue. Pulmonary oxygen exchange, again, ARDS, CHF, all the things that cause massive shunting, and of course tissue hypoxia. So I think the information we're looking for with a blood gas, in my opinion, is extremely important, so that is something that we want to definitely keep in mind. Do blood gases have limitations? Well, absolutely. Number one, we are getting retrospective information. I heard one individual say a blood gas is like a Polaroid from the past, whereas pulse oximetry is streaming video. And that there is some truth to that. Certainly we like the real-time information, but we have not yet found a way to get real-time information with acid base and ventilation, at least not to the degree of efficiency of a blood gas. The blood gases, of course, you know, are the gold standard in those cases. Blood gases are potentially painful if not done correctly, or even if they are done correctly. It is an invasive procedure and certainly carries with it some risk of infection and or blood loss. Unnecessary blood loss, I'll comment later. Certainly that is an extremely important issue among neonates, and it is also a fairly significant issue in critical care patients, and I'll make a few comments on that later as well. Are we going to make a decision based on the blood gas results? So that certainly is probably the key reason. I really tried to get, actually in a couple different sections, protocols and algorithms on blood gases, and there aren't many out there. People, because, you know, they're the signs for acid-base imbalance and hypoxia often overlap, and you know, there are some definite indications, but there are many times when we're not sure. But nonetheless, if we are not going to change our patient care with the blood gas, and that's one of the big limitations, one of the things that we've done poorly, I think, in the past, then there is no reason to do the blood gas. Morbidity, mortality, I am unaware of, situations associated with blood gases, and of course there's always cost. I had done an article previously in the AAR Times, if anyone is interested, I think it was about a year ago, about the cost of blood gases and arguing somewhat whether, you know, are they worthwhile. And I'll make some comments about that as well today. But when we think of cost, my first thought is if we are not eliminating personnel or capital equipment, the costs are sometimes pretty soft, and even though we may charge significantly. So it depends, and we certainly want to think about cost in this day and age, and that is a limitation. It may be expensive. When are blood gases not indicated? In my opinion, and in the research that I've been able to do, I'm old enough that we used to do blood gases for every FiO2 change on a mechanical ventilator. We would change 10% FiO2, and then we would do blood gases in an hour. Certainly with the advent of pulse oximetry, that does not seem to be a very good use of a blood gas. There I would think the dangers are much greater than the additional information. Likewise, minor changes in mechanical ventilation, decreasing a rate from 10 to 8, decreasing PEEP sometimes from 8 to 6, or increasing it. I think you can certainly argue that that would not be a good reason to do a blood gas. Patients with excessive blood loss, again, I think certainly the neonates come to mind there, because the blood losses can be very significant and important. One article, I believe, was called nosocomial anemia, and we certainly want to avoid that. Again, patient care unlikely to be changed with the results. If we have a patient who is terminal, then is there a good reason to do a blood gas every day? If we have a patient that we know we are not going to wean, is there a good reason to do a blood gas? And I think it's, and probably most of the good protocols out there come from the surgery, and in cardiac surgery in particular. We've shown that we can get patients off mechanical ventilators without blood gases, with many fewer blood gases than we used to. So those are reasons, and I will expand a little bit upon that as I move along. But those are certainly reasons that we would, that blood gases would not be indicated. And finally, I just asked the question, is there an easier, less invasive way to get the necessary information? And if the answer to that is yes, then I believe it is not indicated. Key questions, again, because we don't have a list of 5 things that we need to see in a patient in order to say they need a blood gas. I believe we should always ask ourselves some of these key questions. Is the discomfort, which could occur and often does, cost and blood loss worth it? Secondly, will the results appreciably affect care? And nowadays, there have been many arguments that just because the PO2 changes, that doesn't mean that it affects patient morbidity or mortality, and we need to always keep morbidity and mortality in mind. Although I think there is strong data to support morbidity and mortality in severe hypoxia and severe acid-base disturbance. A few final questions that I like to ask myself are, would you want it done for yourself? If you felt, or a family member had a family member that you felt had a problem with acid base, possibly severe acidosis, hypoxia, severe hypercapnia, would you do it? Is the cost really the key question at that point? So that's always a good indicator in my mind. Finally, and I'll mention a little bit about this as we proceed, many of our point-of-care blood gases and even our central lab blood gas machines now have many other analytes available as well. And in fact, indeed, I have seen physicians order blood gases because they wanted a lactate level or because they wanted the electrolytes, and they could get this information both concurrently with the blood gases and most often very quickly. So, I've heard people make the statement that, we want an electrolyte machine that can also do blood gases, or we want a coax that can do blood gases as well, or a lactate machine. So bilirubin, ionized calcium, all those things can be really why you're more interested in the blood gas. Indeed. I'm sure everyone listening to this program would know the 3 sample sites, radial, brachial, femoral, in order of priority. But kind of the interesting question I wanted to point out, first I'll jump down to the very last bullet point and say that CAP has been pretty strict about looking at if people are doing Allen's tests, modified Allen's tests to be more precise, before they're doing radial punctures. Also, if it is not done, they actually, I am aware of places that have said that CAP asked, that it be charted as to the reason it was not performed. The other question I find very intriguing in a way, and I might ask the question, I won't get the answers from you all, but the question I would ask is, do any of you do blood gases? Do you start out to try to do them on the non-dominant hand? And the reason I ask that question, there are some places that do that. The reason being, the only reason I'm aware of, is there was an article by Mr. DeWitt, the respiratory therapist, probably about 10 years ago, where an individual came to the emergency room, had a brachial sample drawn by a nurse, and then had numbness in his right hand the next day, and ended up with some permanent nerve damage in his right hand. Now that's a pretty rare complication, but nonetheless, it was a police officer, in fact, and he sued and he won. I think the award was $200,000 back then, but not at any rate. His argument was based on 2 points. Point number 1 was, why did she do a brachial artery where there's no collateral circulation? And I think we can all agree with that. But the second thing that they argued was, why did they not use his non-dominant hand if there was any potential at all for injury? And the jury felt that was significant. So I thought it's an interesting point. Now, and this is an important conclusion to that little discussion, is that I am unaware of any practice guidelines and that say use the non-dominant hand, whether it be through CLSI or the AARC, and I am aware of no standard of practice that says you should do that. I think the counter argument would be that, I do the blood gas where I get the best pulse, where I can do it most effectively because I'm getting, very important information about the viability of my patient. So I am not saying, to do it on the non-dominant hand, but I thought it was an interesting case and one that I thought you might find interesting to hear about, so I thought I would go to that one. Let me talk about quickly some potential errors, if you will, when you do blood gas sampling. Of course, we all know we can get a venous sample. I think everyone is quite aware of that. The best two indicators would be the flash of blood and also the self-filling of the syringe. But and if you ask individuals what normal venous blood gas is, they will usually, in fact, I've seen some articles about venous blood gases where they say, well, venous blood, it has a PO2 of 40, a SAT of 75%, a pH of 738, and a PaCO2 of 48. Well, that is true of mixed venous blood. So if you drew it from the pulmonary artery, those would be the results you would be looking for. People sometimes forget that, excuse me, I think I went to the wrong slide there. Let me just go back for a minute. Normal variation in peripheral venous PO2 can be quite significant. Venous blood leaving the heart typically would have a 23, skeletal muscle 34, skin, and that's a pretty big difference, and you could get skeletal muscle or skin during an arterial puncture. So there is a huge variation in peripheral venous oxygenation, and I personally would not recommend evaluating oxygenation with venous blood from a localized area. And in addition to that, as the slide that I put up a minute ago, sometimes you will see an individual get a small amount of venous or capillary blood in it, and if you've drawn enough arterial blood gases, it's probably happened to you. And it's just a little bit, and you mix it with, then you get into the artery, and you get a somewhat contaminated sample. I thought it was interesting. I saw these numbers in an article, and arterial blood being 4.5 milliliters. Now, this was just a research study. You wouldn't draw that much blood, but 0.5 milliliters of venous with the PO2 not unlike one of the ones we just saw on the prior slide. But interestingly, with 90% arterial blood, the mixture, just due to that slight venous contamination, would give you a PO2 of 56. So again, there's some information. I believe we would treat a patient with a 56 a lot differently than we would treat a patient with an 86. There is some, and seems to be more commonplace now, that people are talking about also doing venous blood gases. My conclusion, and there is definitely information available to support venous gases if you're looking at primarily pH, especially in the emergency department, conditions such as ketoacidosis or renal failure. I am less convinced that PCO2, and there are some people who believe you can get information, good information about PO2 and PCO2, and certainly you could see if they're way beyond normal limits, and that may have some value. But my conclusion is that if you're just looking at pH, venous blood would be acceptable. Oximetry, probably the electrolytes. If you're looking for some of the other analytes, that would also make some sense. In another article, just to show this, although it was there was considerable correlation between pH and bicarb, and of course bicarb is calculated from pH PCO2, but not PO2 and PCO2. And this particular hospital did not recommend using venous blood for venous PCO2 or PO2 determination. Okay.
Bill, this
the
is
next
point, so you have about
subject that I
25
would
minutes
like
of
to
presentation time remaining.
mention related to blood gases. Yes. Okay, very good. Thanks, Bill. The next thing, of course, we're all aware of is that with air contamination in the sample, that we certainly can have changes in the results. I don't think, in fact, I think the best study that I've seen regarding this, and in the old days, of course, we iced our samples, and that was to slow down metabolism. And then there was research done by several other people prior to this, but in respiratory care in July 2006, after 30 minutes, blood gases in plastic syringes with ice, the PO2 actually went up 14. That's and one of the reasons why the recommendation is not to use ice. But to me, frankly, almost more amazing is that without ice it went up 12. When I first heard this information, I was totally shocked because I thought we iced the sample to slow metabolism, which would consume oxygen. Well, we have since realized that the plastic syringes do allow for oxygen to come from the room into the sample and contaminate it. This will happen to a greater extent when we ice the blood, but it all, as you can see here, and I think this was about the best study done, it still increased 12 millimeters of mercury even without ice. And that's after 30 minutes. The recommendation is typically, and I believe this is true of both CLSI and AARC, is that blood gases in plastic syringes needn't be iced if run within 30 minutes. And this probably all stemmed from the fact that we knew when we iced the sample, if we were going to do electrolytes, we would hemolyze the sample, and that would cause some changes there. And then we actually realized that oxygen was diffusing through capillary syringes, and I would be amazed. If you really want a precise blood gas, you should use a glass syringe, and you should ice it if you're doing research. I tend to suspect in the clinical arena no one is doing that. I think there are very few companies that even make ice samples anymore. And of course, the reason this happens, oxygen will typically increase in the sample because the oxygen in the room is roughly 150 millimeters of mercury, depending on humidity and altitude, etc. But it will usually increase. But it's also interesting to note that air in the sample could decrease the PO2 if you were to get an OR sample where a patient was on 100% oxygen with normal lungs and perhaps had a PO2 of 300 or 400 in the OR. So it tends to migrate towards 150. So, as I said, we want it to be anaerobic, and air can lead to error. Just a quick comment, again, about practice with pneumatic tubes. My research here was I found that pH-PCO2 were not reasonably accurate whether you tube the blood gas or not. PO2 changes, however, could be significant, and especially it depended on if you had air in the sample. And protocol aimed at expelling air prior to sending samples, it was not 100% effective or applied. And I think a lot of times blood gas samples are tubed, pneumatic tubed from the emergency department, and perhaps, I don't know, but I suspect that some individuals that draw those blood gases have not drawn that many and are less proficient at blood gas draws than are some of the respiratory therapists who have done literally hundreds or thousands of blood gases in their careers. So my advice is actually it is probably best not to pneumatic tube the sample. So let me go to the next topic, which is quickly. I wanted to say a couple things about temperature correction, and I think that is, no, that's, I apologize for that. Just give me 1 second here, let me get to temperature correction. I see what happened here. Okay, temperature correction. Thoughts on temperature correction, again, and I have not seen information to change this, but generally in the clinical arena where respiratory therapists work, I do not recommend temperature correction. Reason being, here's an example of a blood gas that was temperature corrected to a febrile patient. Notice the PO2 is 62 on this blood gas, which is reasonably good. If this same blood gas had been drawn at BTPS, PO2 would be 46. Because when we temperature correct blood gases, we just assume that the pressure is higher due to the increased temperature effect. We do not consider the fact that this patient was febrile and probably needed more oxygen than the patient who is at 37 degrees centigrade. Again, I think we would treat the patient with a PO2 of 46 a little differently than we might treat a patient with a PO2 of 62. Recommendations, again, standardized recommendations for temperature correction are, if you do indeed have a physician or want to temperature correct your blood gases, you should also put the BTPS value next to it. So put the temperature in value and then what it would have been at BTPS. This also helps in serial following of blood gases so that you know if indeed the PO2 is any different than the day before. With hypothermia, and this print may be a little small and hard to see, but I'll just read it for you. Solubility of gases increases as temperature decreases. That's actually one of the reasons why your PO2 changes when you cool the blood. In the operating room, it has been, and we think more of hypothermia because of the hypothermia induced for cardiac arrest. But this is kind of a different story, but I was asked this question once, is pH stat, should I use pH stat or alpha pH? And just for your clarification, during hypothermic surgery, they know PCO2 can affect cerebral blood flow and enzyme function, so they add it to maintain the pH and prevent those changes in cerebral blood flow and enzyme function. So during pH stat, that terminology is an OR term primarily at this point, and PCO2 is added. It's kind of like the old standardized bicarb where CO2 is added. And I'm not sure exactly how that's done, but that is the common practice. Alpha pH has been introduced recently as a rival concept, and they do not add CO2, and they cite that it is better, but the debate continues, and I am not sure. I think pH stat is kind of the standard of practice at this point, if you happen to hear those terms. Again, operating rooms. To summarize the errors, I would say I like to come up with acronyms to help my declining memory, and there are 5 things you try to avert: air in the sample, venous sampling, or contamination, excessive or inappropriate anticoagulant. I didn't really discuss that to any great extent. Rate of metabolism. Again, and I didn't mention this, but if the cells that actually consume the oxygen and produce the carbon dioxide in the blood as it sits there are not the many red blood cells, but really the leukocytes. Reticulocytes also do it because they are red blood cells that still have a nucleus, and thrombocytes do it as well. And there have been some of my favorite blood gas cases where people have demonstrated extreme, what they call pseudo-hypoxemia. The term leukocyte larceny has also been used, but those are some things that you would want to keep in mind for, I would say, best practice of drawing blood gases technique-wise. I have previously shown this slide. I said these are some of the reasons blood gases are not indicated. I'm just going to elaborate briefly on a couple points. Obviously, with pulse oximetry, vital signs and all the monitors we have, we don't have to do that all of the time. And many places have protocols for open heart surgery. It's interesting to me, I don't think I have this on a slide, but I had read one article that said that the average critical care patient loses or has about 40 to 50 milliliters of blood drawn per day. And I actually thought that wasn't a huge amount. And then there was one article that said that at their institution, the average cardiothoracic surgery patient had 377 milliliters of blood drawn per day. So I thought that was certainly a good practice. And by the way, one of the things you can do if you want information on these other analytes, which is the last thing I think I will discuss briefly, is that after I finish these complications, but it really makes sense to batch the blood and run co-oximetry and run electrolytes concurrently and lactate with your sample or creatinine. Again, many of these machines have added new parameters that are available. So likewise, again, just to reiterate, we don't need to do a blood gas every time we make a very minor ventilator change. Most clinicians have become pretty adept at evaluating the patient's status with those slight changes in mechanical ventilation. I did say, I already mentioned the blood loss, obviously serious concern in the newborn and batching tests, so some of those things. Quick comment on the idea that blood gases give us retrospective information. We certainly do want real-time information. Hard to make an argument about that, but it's unclear to me. I do think we should actually, if you look back at that study where the PO2 changed 12 and 14 respectively, iced and uniced, or the reverse of that, but double digits. My conclusion was we should try to have a quicker turnaround time, and I wonder if we, came up with a new recommendation about a 5 or 10 minute blood gas. Another thing is, again, the pulse ox is useful, but in ARDSNet and some of the things that we look at, you can't do a PF ratio with pulse oximetry. So potentially painful. certainly in the emergency department, if I have a line in and I can get venous blood and all I want is pH, that makes pretty good sense to me. PCO2 and PO2, I suppose if you're going to run it, you might as well run those, but I tend to think if we really looked at it, they could be potentially misleading. And I do have some concern about going to point-of-care technique, the third bullet point, where we have people who really have no experience in drawing blood gases, who are drawing the blood gases. You're not going to change diagnosis. Again, somewhat of a reiteration, do not resuscitate extremely ill. Certainly not going to do anything with the results. I did say one physician said, I've never had a patient die from hypercapnia, which I thought was interesting. I found this to be interesting regarding the value of looking at acid-base balance. I have one study that had shown in post-op patients more than 50% had metabolic alkalosis. And I'm a big advocate of making sure potassium and the anion gap are correct. And I have also found a more recent study here where, and the date is cut off, but 64% of ICU patients had metabolic acidosis in a large U.S. hospital, and that's recent information. And anything, if you do have any questions or would like me to get you any additional research, I would be happy to do that. Finally, I would just like to comment a little bit about the other analytes. I've mentioned some of the ones that are available depending on the machine, but certainly glucose. I know creatinine's available. Anion-gap sometimes calculated for you, and potassiums. I think those are very important concepts for respiratory therapists. I don't like when a respiratory therapist says the patient has metabolic acidosis, but I have no idea why. I think there is a fairly easy way to find that out. And of increasing significance has been lactate. Lactate's really been kind of a hot subject, in my opinion, in many areas. There are some other ways to get information about these disorders, but lactic acidosis, it still amazes me how frequently I'll have do a blood gas case and tell the students, or the practitioners for that matter, that the patient is severely hypotensive, but they have a good PO2 and a good SAT. And what type of metabolic acidosis do you think they have? And I am a firm advocate that if we are the oxygen therapists, that we should have lactic acidosis primary in our mind. I do a presentation called the 6 types of metabolic acidosis that covers just about every type you will see. It's not really as complicated as we sometimes make it out to be. By the way, here are high anion-gap causes of lactic acidosis, and a little acronym there. Poisoning, renal failure, lactic, and keto. So if the anion-gap is high, and we don't have time to really cover that. I did want to say a few things about the importance of lactate and metabolic acidosis and some of the new ARDS sepsis material. And since I've talked about the importance of metabolic acidosis, I wanted to let you know what the recommendation was, the evidence-based recommendation in ARDS/sepsis. You can make your selection there. At what time would you give bicarbonate? Well, their recommendation is 7.15. So the ideal way to handle a patient with metabolic acidosis is to deal with the root cause, only give bicarbonate if necessary. Again, there was a special issue of respiratory care on acid-base disorders several years ago, and they talked about metabolic acidosis, and I thought it was extremely intriguing that many people feel you should almost never give bicarbonate. Now, there are some who still follow the old rule. I mean, when I entered the field, it was give 1 amp every 5 minutes at a cardiac arrest. That has since been eliminated. Certainly, most people don't feel you should give it to at least 720 in any circumstance, probably even below 710 in ketoacidosis. And furthermore, what was extremely interesting was in one case when they did not administer bicarbonate, the patients actually had an increased survival, and it was theorized that the acidosis actually had a preserving effect on the cells of these patients. So lactate, I think, is extremely important guide in ARDS, sepsis, and trauma. All these things, really, in fact, in the, let me just see here, in the Preventing Sepsis protocol, which, if you're not familiar with the Preventing Sepsis program, I would suggest you go on the internet and take a look at that. It's pretty interesting stuff. I think Dr. Durbin spoke to it earlier, and at one of the international congresses, and the importance of it. But they have found that lactate is one of the things you should be measuring as soon as you think the patient may have sepsis. And indeed, they say when the lactate, which is normally less than 2 or nearly 2, and that, by the way, those units are millimoles per liter. That's how it's usually recorded. Some places will use milligrams per deciliter, and that gives you a much higher number, almost 10 times as high. But when lactate is above 4, they say that you should implement the sepsis protocol, which includes administering fluids, vasopressors, and maintaining the mean arterial blood pressure. And by doing this, there's a much higher rate of survival. So it's really some pretty neat stuff when you start looking at lactate. We had an individual here at our hospital who had they were trying to make ventilator changes last week. This is a good example of actually when maybe you don't want to make vent changes. And the physician said, you know what, no, I don't want to do anything. The lactate is 21, which is extremely high, obviously. There's also pretty much evidence about lactate in trauma. And again, in serial, I've seen charts which are absolutely amazing. I may have something here. In trauma, they talked about if your lactate is less than 2 to 4, and the patient had sepsis, or just trauma, excuse me, not sepsis, there was almost 100% success rate if you could keep the lactate less than 4 during the first day. In emergency medicine, they often talk about the golden hour, the first hour of treatment, but the lactate, if you can keep it below 4 for the first day, there was 0 mortality. It wasn't a great sample size, but on the other hand, when it was greater than 4 millimoles per liter,
about 2 or 3 minutes to
the mortality was greater than 50%. So I thought that was pretty interesting stuff, and certainly something I would want to look at. So I don't know if where we're at with time, Bill, but if we're pretty close to the end. Yeah, I would just, summarize. I have some cases. I don't know that I could jump to those. As far as diagnosing, again, the high anion gap, metabolic acidosis. I'll just make a couple comments on that since I have a couple minutes to finish up with. But the short version of the 6 common causes of metabolic acidosis is that if a patient has a metabolic acidosis, you do an anion gap. I'm not going to do the formula, but if the anion gap is normal, then the patient has probably lost base. There are only 2 ways we lose base from the body. That is either through our kidneys, which can be pharmacologically induced, like a drug such as Diamox, which is the diuretic of choice when you have metabolic alkalosis, or we can lose it through, there are diseases as well, renal tubular acidosis. You may have heard of RTA, where the patient kind of has bicarbonate wasting. I even remember reading an article in Parade magazine in the Sunday paper about these children who had stunted growth because they had lost base and they had RTA. So you can lose base through your kidney, and you can lose base through your intestines, through diarrhea or something like that. Oftentimes we think diarrhea causes metabolic alkalosis, but indeed we lose base and it causes metabolic acidosis. And then to go back to the acronym I had given you earlier, I'll see if I see it here, but the 4 causes of an increased anion gap are poisoning, such as ethylene glycol, wood alcohol, toluene, ethylene glycol, of course, being the primary ingredient of antifreeze. That you would see in the emergency department. In the ICU, we typically see lactic acidosis, and if we have a lactate level, we know that's the cause. If we don't have a lactate level, we need to do an oxygenation assessment from top to bottom, not just a PO2 or SAT, but a cardiac output, a hemoglobin, etc. And finally, the other 2 causes are very easy. Ketoacidosis, most often due to diabetes mellitus, and that patient will be hyperglycemic. Starvation will cause the same thing, but the glucose obviously will not be high in those patients. They both lead to increased fat metabolism and keto acid production. And finally, renal failure of the nature, and that's again where the BUN and creatinine can be very useful, because BUN and creatinine will be significantly elevated if you have a metabolic acidosis. So that kind of ties together some of the reasons why on our point-of-care machines, these other analytes, lactate, glucose, creatinine, BUN, and various, we didn't talk about, abnormal hemoglobin species, can be very useful. And that my recommendation, and I guess my summary, is that I feel like blood gases are one of the best buys for the money. And if you are really concerned about one of those 4 things with me, acid-based, hypoventilation,
we are a little short on time, so I'm going to go directly to the questions. We do have a few questions here that people have raised.
by all means,
quickly address
do a
these,
blood gas on me.
One person asked blood gases daily, in parentheses routine, for all ventilated patients in the ICU. And I guess what they're asking is it, we used to get that morning blood gas, happens to everyone doctors making rounds and stuff like that. Is that an outdated practice?
Well, I think it's controversial, frankly. Again, I think you need to go back to that list. If you're not going to make any changes on the patient, if the patient is terminal, my first thoughts are, what are they doing in the ICU, if that's the case. But if they are in the ICU, and if they're sick enough to be on a $50,000 mechanical ventilator, perhaps that's not a bad idea. Again, I think the value being more the acid-base status, because again, you can't wean a patient with hypokalemia, low potassium, if you look at their electrolytes as well and their lactate levels. As we know, I would like to be following those. I would certainly like to do it. Now, can you argue that you don't need to do a blood gas every day if the vital signs are stable and everything's the same as it was yesterday? Certainly, that practice is out there, and you know. And I'm sure a lot of therapists feel it's a waste of time on certain patients who you've seen, and you know there will, unlikely be a change in this patient. So,
okay, Bill. Another question came
I
up
cannot
about
give you a
perfusion
definitive
issues.
answer.
How about the use of the Doppler to locate pulses?
My bias would be either they shouldn't be in the ICU, or again, I'm thinking of critical care mechanical ventilation versus chronic mechanical ventilation. Certainly, we don't need a blood gas every day there. I don't have any information on that.
That's fair enough, because
unfortunately, I'm a little bit older and have done it the old way. But
there's been a lot of discussion going on during your presentation among the participants.
I guess it makes sense
about various things. And one thing that kept coming up in those discussions was the volume of blood that's needed for analysis. Do you have any recommendations for that?
Evidence or
how much arterial blood is really
I
needed
would feel comfortable giving
to get a minimum amount of arterial blood, I would say, to get a gun out to do an analysis? Mm-hmm.
I would say certainly less than 2 milliliters. Perhaps a lot of the machines can run less. Some of the machines, again, depending on the analytes that you're going to run, may need more. So it's really instrument dependent, and it's nice to have a little bit of extra in case something would go wrong. But I would again refer to whatever instrument you use. What are their recommendations? What's the minimum sample size? Because they have that information out there. And of course, in neonates, you certainly want to use the minimum. And that's been argued, that one machine is better than another because it requires less blood to run a bilirubin, for example. Again, I think that is a key issue. I know that with arterial line draws, you have a lot of blood wasted, or a lot of, there was a good recent article that,
Bill, one quick question, then we've got to get out of here.
Never use
one
arterial
person
lines.
asked,
In fact, I know
actually several
Charlie Durbin.
They wanted to get more information about metabolic acidosis. Where would they go? What's a good source for that information?
A lot more blood gases when they had an art line.
Good reference.
That probably weren't necessary because it was just so convenient. And in addition, you lose more blood. So
there's also Google too. Yeah, right.
Well, I think the best reference would be my textbook. No, well, I would suggest you purchase like 3 or 4 copies of my textbook, but actually I do cover it, I think, in much more detail than most respiratory books because it's an area that I'm very much interested in. However, I would also say the respiratory care special journal issues, they may be 5 or 6 years old, but they were pretty doggone good. There were articles written by some experts, physicians, and I think they covered metabolic alkalosis, respiratory alkalosis, and metabolic acidosis, all 4 disorders.
Good point.
And that was certainly a very,
Bill, with that,
very
we're going to have
article.
to wrap things up here, unfortunately. I want to thank you again for a great presentation. Getting all
I
kinds
would
of
point
accolades
them
over
there.
here in the
Actually, I pulled
discussion
something,
area,
and I didn't have time to read it off
those
the
of you
internet.
watching
And
this
you
live
could Google
presentation,
it, and
please
you
stay with
could
us during the next brief
probably
pause for
find some
instructions on
pretty
how
good
to obtain your
information.
CRC
Just make
contact
sure
hour.
you're looking at
If you're watching this as program is archived, this concludes our presentation.